Today we're looking at Chapter 8, Community Pharmacy Practice. So let's see what happens when Mary isn't feeling well and goes to her doctor to get a prescription. She takes the prescription to a pharmacy, and you might think that the pharmacy would call her insurance company or go online and check to see if she's covered, but they don't. What the pharmacy does is talk to a pharmacy benefits manager using online adjudication. The pharmacy benefits manager contracts with insurance companies, and the insurance companies give them all the details about who's covered and how much to charge for a copay. Then the pharmacy will get that information and know how much to charge Mary for her medication. And then in the end, she's able to take her medication home and use it, hopefully feel better. So that's the prescription process from the time Mary starts feeling ill and then gets her medication. There are different types of community pharmacies. The first one is an independent pharmacy, which is called a sole proprietorship, which means that it's owned by either a pharmacist or another person or a group of people. A franchise is authorized to operate under a well-known trade name, such as Good Neighbor Pharmacy or Care Pharmacy. And a chain pharmacy is, of course, corporate-owned, and you may have seen those, such as Walmart, CVS, Walgreens, Target, Vons, Rite Aid, etc. The primary role of the pharmacy technician is going to be the same no matter where they work. It's to assist the pharmacist in serving patients, basically. These duties can vary depending on the size of the community pharmacy and the experience of the pharmacy technician. And then they'll vary depending on their pharmacy setting. So common things that we do are we provide customer service, we take the information from the patient in order that we need to fill the prescription from their customers or health professionals. We input this information into a computer. We can compound prescriptions, we can package and label prescriptions, price medications, organize inventory, alert the pharmacist to any shortages of medication or supplies, and we can even order them, accept payments for prescription and process insurance claims, and arrange for customers to speak with the pharmacist and other pharmacy housekeeping tasks. There's different types of medications, of course, and they come in different classes depending on how you can purchase them. For instance, OTC stands for over-the-counter medication, and it does not require a prescription to purchase. You can walk in and buy over-the-counter acetaminophen or Advil or something for sinuses maybe. BTC is a middle class. They started this several years ago. It's called behind the counter. It doesn't require a prescription, but it requires a pharmacist intervention to be sold to a patient. So an example of that is Plan B or Sudafed. And then a prescription drug is also called a legend drug, and it requires a physician's order in order to be dispensed. That's what the RX symbol stands for. The brand name or trade name or proprietary name are all terms to indicate a name that a company has a patent or trademark on. So it's often followed by the little R with the circle. There is only one generic name for any prescription drug. There are a lot of different laws and regulations. The Combat Methamphetamine Act of 2005 subclassified the over-the-counter medications into the behind-the-counter medication. So when you're dealing with something like Sudafed, which people can make into methamphetamine, it has to be purchased under pharmacist supervision. They must provide proper identification. They have to be at least 16 years of age. It may be 18 in some states. They can purchase up to 3.6 grams per day, but no more than 9 grams in a 30-day period. Sudafed is a nasal decongestant. It works by squeezing the blood vessels and forcing out liquid, which causes the congestion in the sinuses. So here's some examples. Sudafed, Zyrtec D contains Sudafed along with an antihistamine. And then there's a picture of Plan B as well. Prescription medications are also known as legend drugs. That's because they carry the federal legend or this warning on them. It says no dispensing without a prescription. It says, caution, federal law prohibits dispensing without a prescription. But now they can just put RX only, which means the same thing. Here's a manufacturer label. It has to have several different things on it, including the NDC number, the brand and generic name of the drug if it's a brand name drug, the strength, the form, what the tablets look like, the expiration date has to have a barcode with the NDC number encoded in the barcode, as well as the place that it was manufactured. There are a lot of different ways patients can get their prescriptions at the pharmacy. They can walk in with an actual paper prescription. The patient can mail in the prescription to a mail order pharmacy. The physician's office can fax a patient's prescription to the pharmacy if it's not a controlled substance. Prescriptions may be called in a verbal order given to the pharmacist, and then of course e-prescribing, which is where doctors input prescriptions directly into a computer and it goes to that same health facility's pharmacy, or it could go to a community pharmacy that has a deal or a contract or an agreement with the doctor to accept those e-prescriptions. E-prescribing is the computer transfer of prescription data. So it also can give messages about new prescriptions and prescription changes. They can also send refill requests and prescription fill status, prescription cancellation, medication history, and it involves many participants in the healthcare system. The advantages of e-prescribing, and one of the #1 advantages is to reduce errors due to poor handwriting. We always said that doctors spent so long in medical school that their handwriting just deteriorated from taking notes for so many years, back when they had to take notes with a pen and paper. And I also think it's due to them being very busy when they see patients. So the e-prescribing reduces errors from that. It expedites refills, it links the patient's medical and prescription files, and enables prescribers to receive drug-specific dosing and notifying prescribers if a drug is covered or not covered by a patient's insurance, and also facilitates the data exchange between the physician and the pharmacist. There are 5 basic steps for refilling a prescription. The first one is receiving the prescription. The second one, translating the prescription. That's where we see if we can read it. 3, entering the information into the computer system, and that's also when we bill for the prescription. And then filling the prescription itself. These first 4 steps can be done by technicians. Number 5, patient counseling. That's always done by a pharmacist or a pharmacist intern. Computer-generated prescriptions are becoming more and more common. Controlled substance prescriptions must be printed on security forms, and they may be provided to patients on discharge for hospitals or physician's office. So all prescriptions have to have, whether they're written on paper or put in through a computer or called in, they have to have the prescriber information, which is the name of the physician, their office address, telephone number, license number, national provider information number, or the DEA number. If it's for a controlled substance, it has to have the DEA number. The date the prescription was written, the patient's information, their name, home address, age or date of birth, and any allergies they may have. The 4 main parts are the superscription, the inscription, the subscription, and the signatura, which is the SIG, which are the directions. It has to have refill information, whether or not a brand name drug is necessary, and that's using a DAW code, and the physician's signature. The physician's signature must be in ink. Stamped prescriptions are illegal, but we still see them, and depending on what the drug is, we may actually fill them. So here is an example of a prescription, and it should have all of that information on there that we just talked about. The 4 main parts of the prescription form. The superscription is the symbol RX from the Latin recipe, which means take. The inscription is the name of the medication, the strength, quantity in metric, and the dosage form. The subscription is not on every prescription. It's special directions to the pharmacist on how to compound the medication. So if it's not a compounded medication, it will not have a subscription. The signatura is something that we call the SIG. We usually take it to mean directions. It's usually preceded by an S to represent the Latin signa, meaning mark. The signatura is where the healthcare provider indicates what instructions are to be put on the outside of the package to tell the patient. And also the pharmacist keeps a file of all prescriptions filled. They're required to be kept on the premises for 2 years. So here is that example, another example with all of this information on it. Now this one is for a compounded medication, including phenobarbital, simethicone, and magnesium carbonate. And these are to make capsules for a patient. So the superscription is the RX. The subscription is the instructions to the pharmacist how to compound this. There's a refill information on there. There's prescriber information, a DEA number, patient information, the date the prescription was written. The inscription is the name of the medication prescribed, and the signa is the directions for the patient. And then it also has the doctor's signature and whether or not it's dispensed as written. The patient profile is a list of all the patient's prescriptions that they have filled at that pharmacy, and all the related information, including the original date of fill, the dates of refill, and the prescribing practitioner. This is required by the OBRA 90 Act. This is a tool that can help eliminate medication errors. It's helpful with drug utilization, DUE, drug utilization evaluation. And it also has the information for the patient, like their complete name and address, telephone and date of birth, and insurance information. When a patient first comes into the pharmacy, we have to ask the patient if they've filled medications at our pharmacy before. If they have, we want to make sure that we choose the correct patient. So we want to make sure that we are going to match up not just their name, but also their date of birth and any other information, so that we have the exact patient that we want, because so many of them have the exact same name. If we don't have all that information, we need to collect it. The patient's complete name, their home address, telephone number, date of birth, all their allergies, current physical condition. That might mean you're not going to look at them and say, yeah, they look great. No, what you want to know is, do they have any special diagnoses that we need to have on file, like diabetes or high blood pressure? We need their insurance information, whether they want to receive generics and over-the-counter or behind-the-counter meds or herbal supplements that they take. Drug utilization evaluation, we used to call it drug utilization review, but that sounded like DUR, and that wasn't very nice. So now we call it DUE, compares all the medications in the profile. Now this is only as good as the medications that are in that profile. For instance, if they get medications at another pharmacy, it won't be in our computer system. It'll be in the other pharmacy's system. If you're at a large chain pharmacy like Walgreens and they tell us which other pharmacy within the Walgreens system they went to, we can access that other information, but it's not easy. We have to actually log into their specific system, and it takes time, and it doesn't give us all their information. So they have to let us know by telling us, what they got at other pharmacies. This can help with drug-food interactions, drug-disease interactions, incorrect dosages, incorrect treatment duration, etc. Sometimes prescriptions are hard to decipher. So if it looks like you don't know what it means, you can't read it, always ask another technician and then verify with the pharmacist as well. When we enter that information into the computer, we want to make sure that we check the label that's printed so that we know that we did it correctly. This is going to generate two labels. One is for the patient vial that they're going to take home with them, and the other one goes on the back of the original prescription. Pharmacist's initials are needed on both labels. Some states require technician initials also. We always initialed our labels, but lately when I pick up prescriptions, I notice that they aren't necessarily initialed on the label that's on my bottle, so maybe they don't require that anymore. DAW codes, these are called dispense as written codes, and they're a set of numeric codes created by the NCPDP that are used when entering prescriptions into the computer. Now the NCPDP stands for National Council on Prescription Drug Programs, and this is like a big council of all of the insurance companies that have prescription programs, and they have to have an NCPDP number for the pharmacy if you're going to fill prescriptions for that particular insurance plan. The list of acronyms and abbreviations to know for the DAW codes are on page 177, box 8-1. There's 0 through 9, which gives it 10 codes. If the code is not submitted properly, it can affect billing and reimbursement. So let's say that the patient wants naproxen instead of naproxen, which is the generic. Now, the generic has been available for years, so the insurance company would not normally pay for it unless the doctor writes DAW1, which means the substitution is not allowed by the provider. Now, I don't know why they would do that, because the generic works just as well. And in fact, even if the doctor writes DAW1, most of the time the insurance company will charge at least twice the regular copay. So it's not necessary, but a lot of patients think they have to have brand name drugs. The prescriber is the person writing the prescription. And the prescriber information that has to be on the prescription are the prescriber's name, address, and telephone number. And they might also need a license number or national provider identifier number. If it's for a controlled substance, it has to have a DEA number. The DEA issues a number to practitioners, and this must be on the prescription if the drug is a controlled substance. This number can be verified mathematically. Okay, all prescribers that are given a DEA number, it's a 9-character unique identification code, 2 letters and 7 numbers. Now, the first letter is either A, B, F, or M. A is one of the first letters they came up with, and it's been around for so long that they've used up all the numbers after it, so it's older, it's not issued to new doctors, but we see B and F also. M indicates a mid-level practitioner, and they must work under the authority of a physician. Mid-level practitioners include nurse practitioners, certified nurse midwives, physicians, etc., assistants, etc. The second letter is the first letter of the physician's last name. There are 7 numbers in total. 6 are used to verify the DEA number, and 1 is a check digit. So the way that we figure this out is we add the first, third, and fifth digits of the DEA number. Step 2 is to add the second, fourth, and sixth digits of the DEA number. Multiply the result of step 2 by 2, and then you add step 1 to step 2, and the last digit of that sum must be the same as the last digit of the DEA number. That's why they call it the checksum number. This is all in last week's Zoom meeting, and we did a few examples in the last Zoom meeting. So here's an example. Dr. Benjamin Pascoe's DEA number is AP5836727. So if we're going to verify that DEA number, first of all, the first letter is an A, B, C, or F, so it's an A. The second letter is P. Well, that's Dr. Benjamin Pascoe, so P matches the first letter of his last name. So let's look at the numbers. We're going to add up the first, third, and fifth digits, which is the 5 plus the 3 plus the 7, and that gives us 15. Now we start with the second number, the 8, and we're going to add the 8 plus the 6 plus the 2, and that will give us 16. The second part we're going to multiply by 2. 16 times 2 is 32. And then we add up what we got when we added up the first digits and then the third section. So 15 plus 32 is 47. And the check digit is 7, which is the same as the last digit in the DEA number here. The last digit in 47, which was the answer we got. So that is a verified DEA number. This example asks you what the 7th digit in Dr. Andrew Shedlock's DEA number should be. So there's the whole DEA number except for the last digit. So it starts with A, B, C, or F. Yes, it starts with a B. The doctor's last name is Shedlock, and the second digit is S. So then we add up the 4 plus 2 plus 8 and we get 14. Then we add the 5 plus 5 plus 9, which gives us 19. 19 times 2 is 38. 14 plus 38 is 52. So the last number in the DEA number should be a 2. After we prepare the label, we want to make sure that we match it with the original order, which is the prescription, and then fill it. So there's 10 important steps in filling prescriptions to follow to avoid errors. Okay, the first one is we verify the prescription. We check the label many times before it reaches the patient. Hold the original prescription next to the label, look at it. Are you matching everything? Is generic substitution allowed, or is brand name medically necessary? Then we want to go to the shelf and choose the correct medication. Now, if you remember from chapter 5, some drugs will come in different forms, and some drugs will have continuous release or extended release formulations. For instance, metformin comes in 500 milligrams or 500 milligrams extended release. So we want to make sure we choose the correct one. We want to compare the NDC numbers with the drug that we chose in the computer. We'll have an NDC number, and we want to compare that with what's in the bottle in our hand. Check for bottles marked with an X. If there's an X on the front of the bottle, it will indicate an open bottle that should be used before we open a new bottle. If we're going to put the label right on the manufacturer's bottle, let's say we're giving them a whole bottle of 100 tablets, we want to make sure we don't cover the drug name, the NDC number, or the expiration date. 3 and 4, counting and filling the medication. Check the label and prescription against the bottle for accuracy. Double check the NDC number. Counting trays are still used. It's best to count in multiples of 5, and you remember we have a video from a couple of weeks ago of counting pills. To prevent contamination, we have to wipe the tray clean with alcohol between each use. There are digital counters and automated counting machines also. Baker cells are used in larger pharmacies. Calculating the day's supply, we always round to the nearest whole number. It says the nearest whole number. We always round down. For instance, if they're supposed to take 4 doses in a day and they're taking it 4 times a day, and that last day they'll only get 3 doses, we don't count that last day. So I don't agree with this rounding to the nearest whole number. You round to the number of whole days. This is a Kirby-Lester counting machine. The tablets are poured in through the top, and they need to be poured slowly because the middle section has a laser beam that every pill that falls through breaks the beam of light, and they count how many times the light is broken. Then they fall down into the clear tray at the bottom, and they get poured into the patient's dispensing bottle from there. This is a Baker cell counting machine. And it's a large cabinet with medications in these cells, and you go to the blue numbers on the left and you tell it which cell you want to count from and how many tablets you want to pour out of that cell. Then you hold the patient bottle underneath the little chute, and it shoots out the correct number of tablets. This is a Baker scale. This is used for tablets that are not extremely tiny. It will not weigh extremely tiny tablets very accurately, but it weighs larger pills just fine. So you scan the barcode on the prescription bottle, and then you scan the barcode on your dispensing bottle, the stock bottle you're going to pour the tablets from. And it tells you if it's correct or not, if you chose the correct drug. And then you pour them a few at a time into the little white weighing boat, and it tells you when you've hit the correct number of tablets. And then you can pour them into the dispensing bottle from there. This is a Parata Robot, and it works similar to the Baker cell system, where you tell it what you want, and then it automatically fills it, and it actually does everything except put the lid on the bottle for you. They use these automated dispensing systems for 3 reasons. The first reason is if these things are loaded correctly, they can cut down on errors. They increase productivity because they're pretty fast, And inventory control, because they let you know when they run out of tablets. Automated systems can visually identify all the info on a label through a barcode located on the side. So here are some different names of some of them. Parata, Omnicell, Kirby-Lester, Script Pro. The one we use at the hospital I work at is called AccuDose, and it's owned by Ascent. And I believe Ascent also bought out Omnicell a few years ago. We have to put the correct lid on the medication after it's filled. Most of the time, these are going to be child safety lids where you either push it down and turn, or you push down on a little lever on the side of the bottle, and then you can open it that way. Older patients sometimes don't want child safety lids, so we can put a snap-on or screw-on lid on top of that. Nitroglycerin is an exemption to the Poison Prevention Packaging Act, because nitroglycerin is a drug that has to be used in an emergency. And if the patient is having severe chest pain, they may not be able to operate child safety caps. So for nitroglycerin, if the patient doesn't want a child safety cap, they don't. In fact, they don't usually come with a child safety cap. Also, if the patient requests non-safety caps, we're allowed to fill all of their medications with non-safety caps. We just warn them, you know, if you have little children around, make sure you keep them out of their reach. When we put the label on the bottle, we want to make sure that we put it on straight. And I've done this for so many years, and I've always had the problem if I go too fast, I'll put the label on at an angle instead of straight up and down. So then I'll have to take it off without tearing it and put it on again. So we also have to put auxiliary labels on the medication bottles, and we're going to look at those in a minute. The information that's required by law on a prescription label that goes to the patient. Okay, so this is the information on the bottle that the patient takes home. These are California requirements. Your book lists the first 11. The name, address, and phone number of the pharmacy. That's because they have to know where they got their medication. The prescription number, the patient name, the drug name, strength, and dosage form, the manufacturer name, the instructions for use and how many you're giving the patient, the date filled, the refill information if they have refills or not, who the prescriber was, the expiration date, except now we call this the best use date or by use date or beyond use date. We just call it the BUD, and the initials of the pharmacist and or technician. And in California, they also have to list a description of the drug. For example, round beige tablet CL12, which means it's a round beige tablet, but stamped on it will be the letter CL and the number 12. And that is just an example of one. They're all different. So here's the label that goes to the patient, and there's all of that information we just talked about. The technician's initials are number 7. They should initial all orders that they fill. Some pharmacies in some states require it by law. The pharmacist gives the final checkoff and knows who filled it by the initials. The pharmacist can ask the technician or notify them if they notice any discrepancies or errors that are made when filling the prescription, and then they must always sign off after completion. Auxiliary labels are extra information that you want the patient to pay special attention to, mostly auxiliary labels. And on page 178, table 8-4, you have a list of commonly used labels, and they look something like this. Nine and 10 is the last step in filling prescriptions, is we pass the filled vial along with the medication container from the shelf and the original prescription to the pharmacist. Filling one prescription at a time is important to avoid errors. Okay, the National Drug Code, we talked about this in Chapter 2 as well. It has 11 digits. The first 5 digits indicate the manufacturer. The next 4 digits indicate the drug product, the name, strength, and form. And the last 2 digits are the package size and packaging. If a drug is reformulated, it gets a new NDC number. If the drug manufacturer purchases another drug company, they have to come up with a name for the new drug company, and the NDC number will change. The NDC number is a guaranteed way to verify that you've got the correct medication that you put on the label of that drug. There are also these things called lot numbers. They're assigned by the drug manufacturer to identify a given batch of medication, like where it was made and when it was made. The expiration dates are assigned by the manufacturer and ensure the amount of time the drug will be pure, safe, and effective. It's a legal document on the bottle that says that we will guarantee it as long as it's stored properly up until this date. And in fact, the expiration date, this one says 5/21. Let's see. Expires 05/21, and it actually expires the very last day of May at midnight in 2021. So an expiration date is good all the way till the very last day of the month at midnight. Now, when we get a drug recall, we look at both of those things, the lot number and the expiration date, and we use those to recall a drug. We have the 5 rights of medication safety. The first one is the right patient. We always want to give the right patient the right drug in the right dose, by the right route, at the right time. And then we've always said in pharmacy there's a 6th right. And you want to make sure you do all of this using the right attitude. You want to fill prescriptions as if you were filling that prescription for someone that you love. For medication pickup, patients can wait for their prescriptions. They can have prescriptions delivered. They can pick it up later by them. They can pick it up themselves, or a relative can pick it up. All third-party prescriptions must have the signature of the person receiving the medication, and you have to check their ID before releasing medications for controlled substances. Okay, OBRA 90 gave us the legal requirement for a pharmacist counseling of a patient or the patient's representative. An offer to counsel must be made to every patient, but patients may refuse. This is federal law. It says that all new or changed prescriptions for patients on Medicare or Medicaid need consultation, and that includes the name and description, of the medication, the dosage and form, the route of administration, duration of therapy, as in how long they expect that they'll have to take it for. If the dose is missed, what do they do? What are the usual side effects? Are there any special directions, such as don't take it with alcohol? How do they store it? How many refills are on it? So all of that is in the patient counseling that they get from the pharmacist. This is why I love OBRA 90, because before OBRA 90, pharmacists were filling prescriptions. And after OBRA 90, they were busy counseling patients, so now we fill the prescriptions. Okay, if the patient has insurance benefits, they're going to have a card with a group number. And the group number identifies the coverage that they have under one contract with this insurance company. The subscriber number identifies the individual who pays the premiums. The person code identifies the specific individual covered. For example, it may have an ID number and then 01 for the card holder, may have the same identification number with 02 for their spouse. Then we have a billing identification number, BIN. It's the 6-digit number used for routing and identification of pharmacy claims. And this is assigned by the NCPDP again. And it should also have a help desk telephone number. Here's an example of a Blue Cross Blue Shield card. Now, just because the patient came in with this card does not mean that they have this insurance now. So this is why we always run them through the computer, and we check with that pharmacy benefits manager for the plan, and then that will give us either no, this patient is no longer covered, or it'll have some reject codes, which we're going to talk about in a minute. Online billing of prescription claims is called adjudication. It only takes a few seconds, and it provides reimbursement for the pharmacy as well as what amount the patient will be responsible for. If the patient doesn't have third-party coverage, which means insurance coverage, then they're charged the full price of the medication. Most pharmacies will accept cash or credit or a check, and each type of insurance has limitations and conditions. Now, if the patient got a 30-day supply, most insurance companies will pay for it again after 90% of the time has gone by. So if it's a 30-day prescription and there's 3 days left out of the 30 days, you can usually fill it again. If you try to fill it earlier than that, you'll get a rejection code 79, which means refill too soon. So you need to check with the patient, how is the patient using the medication? For instance, if they're supposed to take it twice a day, but they're taking it 3 times a day, they either can't have it yet, or they need to get a new prescription from the doctor saying 3 times a day, so the insurance company will pay for it. If it says as needed, and they can take it 3 times a day, you want to make sure that the estimated days supply in the computer is correct. Now remember, ask those open-ended questions. Don't just say, oh, you must be taking it 3 times a day, right? Instead, just ask them how they're taking it. And check with the insurance company to see if an early refill is allowed. For instance, some insurance companies will allow 1 time per year vacation refill, which means that they can get it early because they're going to be out of town when they need to refill that prescription. So page 177 gives you a bunch of prescription claim rejection codes. Some of them might be wrong date of birth, some of them might be wrong gender, or no longer has this insurance. Okay, the patient product information is a pamphlet that we give out or an information sheet that we give out with each drug to the patient. It has the clinical pharmacology, the indications and the use, the contraindications, warnings and precautions, adverse reactions, possibility of drug abuse and overdoses, and there's an example of Enbrel. Okay, so if we finish filling the prescription, what do we do with that piece of paper that they gave us, that prescription that they gave us? So what we need to do is we have to keep them on file for 2 years. So we keep them and we put them in a file and we file them away. So there's 2 different ways that we can do this. This is through the 1970 Controlled Substance Act. We could have a file for C2s, which are the highest level of controlled substance, and then a separate file for Schedule 3, 4s, and 5s, and then another file for all non-controlled drugs, all the blood pressure medication, hormones, and that type of thing. Or we could have 2 separate files. So one for all controlled substances and one for all non-controlled substances, and this is usually how most pharmacies do it. Or you can just put C2s separate. And if you do that, then you put the C3s, 4s, and 5s in with the non-controlled prescriptions. You have to stamp those prescriptions with a red C so that when you're looking through the prescriptions very quickly, you can see which ones have controlled substances on them. And then all the electronic files for the e-prescriptions have to be kept for 2 years as well. So here's the red C stamp. And it's also on the bottle. That's a bottle of Norco right there. Hydrocodone bitartrate and acetaminophen. Prescription refilling, patients can call in their prescriptions, they can do it electronically. Let's say that we want to ask the doctor's office for a refill because the patient doesn't have a refill left, but they can't get an appointment to see their doctor for another month. So we can call the doctor's office and ask them to refill it again. And technicians can do this. Most of the time we do this electronically or with a fax machine. In order to do that, we have to be able to give the doctor's office the patient name and phone number and their date of birth, as well as the prescription name, number, strength, and the doctor's name. And then they'll let us know either by, again, electronically or fax or phoning us if it's okay to refill that prescription. If the prescription is for a Schedule 2, there are no refills allowed, so the patient has to go get a new prescription from the doctor. Prescriptions for controlled substances are valid for 6 months from the date is written. When the prescription expires, so do all the refills. C2s are not allowed to have refills, so they have to get a hard copy new prescription each time they need a fill. C3s through 5s, the doctor can write for up to 6 refills because the medication is good or up to 5 refills. The medication prescription is good for up to 6 months of the date that it was written. If the patient gets a partial on a refill, they forfeit the remaining amount. Legend medications, non-controlled prescriptions, are valid for 1 year from the date written, and non-controlled prescriptions can have a total of 11 refills, which is a total 12-month supply from the date it was prescribed. Let's say that the patient moves 60 miles away and needs to transfer their prescriptions. That's just an example. They might want to transfer them for other reasons, hopefully not because they don't like the technician. So transferring a prescription requires the date and all information for the receiving pharmacy, the name of pharmacist and the number of refills, the NABP and DEA number of the receiving pharmacy. This information has to be recorded by both the transferring and receiving pharmacies on the back of the original prescription or in the computer. A prescription can be transferred only one time. In California, only pharmacists may transfer prescriptions to or from their pharmacy, but technicians can gather information for the pharmacist to assist, and then the pharmacist performs the transfer. There's techniques for detecting forged and altered prescriptions. Sometimes legitimate prescriptions pads are stolen from physicians' offices and prescriptions are written for fictitious patients or, just large amounts of drugs. Drug abusers could get a legitimate prescription and then alter the prescription to obtain larger quantities of medications, or they could have prescription pads from legitimate physicians printed with a different callback number, and drug abusers could call in their own prescriptions. And also computers can be used to create or copy legitimate prescriptions. So we have to be really careful these days because pharmacies can get in a lot of trouble for filling these forged or altered prescriptions. So there's different signs that we can look for that a prescription was not issued for a legitimate medical purpose. If a prescriber writes for significantly more prescriptions or larger quantities than other prescribers, we sometimes call those Candyman, or if the patient returns too frequently, or if the patient is presenting prescriptions that were written in the names of other people, or if the medication prescribed is not within the scope of their practice. So, for instance, if a dentist is writing prescriptions for something for seizures, for instance. Characteristics of a forged prescription. Sometimes these prescriptions will look too good. They look so perfect that you know that a doctor didn't write them very quickly on the way out the door. The prescriber's handwriting is too pretty. The quantity, directions, and dosage differ from the usual medical usage. The prescription doesn't comply with acceptable standard abbreviations or appears to be too textbook. If it appears to be photocopied, what will happen is the security form, when it's photocopied, will show the word void across the front of the prescription. We never fill that, of course. Or if the directions are written in full with no abbreviations, or if the prescription is written in different colored inks or pens or handwriting. Now what happens is we get to know the doctors in our area and how they usually write prescriptions. We also get to know our patients. So we can look at a prescription, know the doctor's signature, and sometimes we even know their DEA number. We know which prescriptions patients usually bring in. So if there's a discrepancy, the patient must have a plausible reason before the medication is dispensed. When in doubt, we want to request proper identification from the patient. If you believe you have a forged or altered or counterfeit prescription, don't dispense the medication. Alert the pharmacist and contact the local police. Sometimes that's up to the pharmacist to decide to call the police. If you discover a pattern of prescription abuses, you want to contact the Board of Pharmacy or the local DEA office. Pharmacies will have all different kinds of layouts, but they will all have an intake window area, like an in window or out window, a bench or production area, that's where the prescriptions are filled, a stock area where all the different medications are kept. They may have fast movers close by. They're going to have a non-sterile or sterile compounding area away from all the other workflows so that you don't have distractions or dust. and a pharmacy order check-in area where they check in deliveries, and a reconstitution area where drugs that are in powder form are reconstituted into a liquid. They might have a repackaging area if they do repackaging, an area where they store the original prescriptions. They might have bins where prescriptions awaiting pickup are kept. The prescription pickup window where they pick up and pay for their medication. They'll have a consultation area, which is law now. They have to have a separate consultation window. And some pharmacies will have a drive-through window, which I don't agree with. I worked at one and it was not fun because patients would want me to go get things from the store area that I couldn't leave the pharmacy to go and get. So they were always very disappointed with the drive-through window. So here are some, here's a picture of a pharmacy layout. Remember, we talked about communication. It can be verbal and non-verbal. So make sure you ask those open-ended questions, listen and make eye contact, be empathetic, watch your tone of voice and your gestures. When you interact with the pharmacist, you want to make sure you communicate in a clear and concise manner. Use proper terminology. The pharmacist should listen intently and request clarification if needed, listen and provide feedback, and make sure that we always provide patient-centered care. So patient-centered is not we're tired and we want to go home. Patient-centered means the patient needs this medication tonight. So we're going to stay and give it, make sure that they are able to get that medication, or at least some of them. We have a lot of different challenges with our different patients. One group of patients is elderly patients. Sometimes they experience more chronic conditions, which are long-term conditions they've had for a while, things like arthritis, which means more necessary medications. They process information at a slower rate, so when we talk to them, we want to base our speech on their ability to understand us. They can develop bodily changes or hearing impairments. Some elderly people have to read lips, even if they have hearing aids, and I wear hearing aids. They're not always perfect, and they don't always tell me what someone said if they're mumbling. We want to make sure we keep our sentences short and simple. Some patients will also have speech. Now I'm having a speech impairment. Speech impairments such as dysarthria and aphasia. If patients are terminally ill or mentally ill, there's more challenges there. For instance, mentally ill patients might not want to speak with the pharmacist because they might have a poor self-image or hesitancy interacting with people. They might know that we know what their prescription is for, and they're embarrassed about having something like depression or maybe some other mental condition which they're really embarrassed about. The staff might have difficulty relating to the patient. They might not know how much information to give. We don't want to hand someone a medication and say, this is because you're psychotic. So that's not good. Also, terminally ill patients, they need supportive relationships. Terminally ill means that in the opinion of a medical doctor, if their disease progresses the way that most of these same diseases progress, that they will probably pass away within 1 year. That's the definition of terminally ill, but patients should always get a second opinion because those opinions may not coincide, and we don't always know for sure if a patient is going to die within 1 year. What's the time frame? We don't know. So these patients might be going through the stages of grief if they've lost a loved one, or if they are going through grief at their own impending death. So those 5 stages of grief, as identified years and years ago by a famous psychologist, are denial, anger, bargaining, depression, and acceptance. If the patient is in denial, anger, bargaining, or depression, it can be difficult to deal with them because they may take it out on you, and they may be angry, and it may show when they come to the counter, or they may be depressed and very sad. I've had more than one patient come to the counter crying because somebody they loved had passed away recently. Okay, patients with health literacy issues. This says that 90 million people in the US are at risk because they have difficulty understanding and acting on health information. Now, it could be their literacy skills that sometimes can affect their health status or predict their health status. Many minorities have literacy problems. They may not be able to read or read in English, or they may not understand health and medical terms. Lower literacy means higher healthcare costs. Poor understanding can lead to medical errors and lack of compliance and increased risk of hospitalization. And we covered all of this in chapter 4, I believe. So this is an issue that exists everywhere in the world, and even in areas in the United States where people, make a lot of money and may possibly have advanced degrees. There's still going to be other people that aren't health literate. The caregivers must understand the patient's condition and treatment and communicate effectively, but we can't give them more information than they need to know either because of HIPAA laws. The pharmacy staff should demonstrate empathy toward the patient and the caregiver. The sensitivity of their condition may keep many people from seeking medical attention. So the pharmacy needs to develop trustworthiness by being friendly, ethical, and fair. Also avoid words with multiple meanings and medical jargon with caregivers unless you know that they know what these things mean. Most of the times we want to use simple words, and recognize cross-cultural styles of speaking. Some people may use terms that I might not understand for different things. Okay, with customer service, it's very important that pharmacists provide the information that will maximize the therapeutic effects of their medication. So again, we're looking at the right patient, right medication, right time, right dose, right route. We need to be well-groomed in appearance. We need to have a good attitude by keeping up our field of study and being courteous. We want to make sure that we're efficient. We don't want to waste a lot of time by doing something wrong the first time and having to do it all over again. And we also want to have, with our good attitude, the idea of helping out. When our coworkers are overwhelmed or extremely busy and we're not, we want to make sure that we help them. Now let's talk about immunizations for a minute. These are vaccines to prevent specific diseases. In California, they can only be administered by pharmacists. In other states, technicians can administer immunizations. In any state, pharmacy technicians can help facilitate those immunization programs by getting the insurance information and billing for it, as well as handing them, getting their patient information, making sure they receive the information on the vaccine or immunization that they're receiving. We want to reduce barriers to superior service, so we can help with that documentation, billing, and reporting adverse effects. We can even draw the correct amount of vaccine into a syringe for the pharmacist. And we can also obtain cardiopulmonary resuscitation training, CPR, and advanced life support certification. Other services offered by the pharmacy, one very important one that a lot of pharmacies are doing right now is medication therapy management, MTM. Pharmacy practices must evolve to ensure success. So one of the things they do is they look at all of the medication that the patient is taking from all of their different doctors, and they'll actually make an appointment with the patient, and the patient will be asked to bring in all of their bottles of medication, as well as things like, their supplements like calcium, vitamin D, anything else that they're taking over the counter, and things they got at other pharmacies as well. And they can bring that in a plain bag and talk to the pharmacist about it to see if there's any issues with them not wanting to take certain medications together, not wanting to take certain medications at bedtime because they cause heartburn, or maybe they've gotten meds from 2 different doctors at 2 different pharmacies that do the exact same thing. So that's duplication of therapy, and it can also cause increased side effects. So we want to make sure that they don't do that. So this medication therapy management is only performed by the pharmacist, and they do get reimbursed through Medicare and Medicaid to do this. So since so many elderly people have something called polypharmacy, which means they go to more than one pharmacy and they get quite a few medications, it's important that they have access to this medication therapy management. One of the other things that community pharmacies can do is prepare medications for long-term care facilities, correctional facilities, assisted living facilities, and boarding care homes. So they do the data entry, repackaging, and labeling medication, processing return medications, and providing necessary forms to these facilities. And they'll do something called a card fill, which is a 30-day supply of medication in a blister pack with 30 or 31 blisters on it for their medication for that day. In home health care, this is another thing that we do. This is where pharmacies will prepare medications for patients at home, and let's say that the patient has an injury that doesn't require them to be in the hospital, but maybe they need an IV infusion of medication once a day or twice a week. So then a nurse will come with the medication from the pharmacy and they will administer that IV. We also do prepackaged medications, those little blister packs with all your meds for one day in it. They also sell medical devices. And in recent years, there's a lot of different things that are now provided by pharmacies. It's called durable medical equipment, wheelchairs, hospital beds, oxygen therapy, first aid kits, prosthetic and or orthopedic devices. Also things like walkers and the chairs for the shower as well. Okay, so that pretty much covers community pharmacy in a nutshell. So if you have any questions, be sure to email me with those questions and I'll do my best to answer them.